Thank you for coming to our Research Fundamentals talk for October. We are pleased to have Dr. Payakachat here, who is going to talk to us about patient-reported outcomes. I think this should be a really interesting talk, so thank you for being here with us. And without much further ado, I will turn it over to her.
Hi, everyone. This is Nalin Payakachat from the Division of Pharmaceutical Evaluation and Policy, College of Pharmacy. So it's a pleasure to talk with you to the topic of, I hope that will be interesting topic for everyone, is tips and tricks in measuring patient-reported outcomes. So first of all, I would like to know the audience to see, please tell us who you are and what is your primary work. So we can kind of see, the audience, a proportion of clinicians, researchers, or you do teaching, or your students. So if I hope the poll works.
It looks like everyone has answered, so I will end the poll and I will share the results.
Okay, so we have the majority are researcher or doing research, and also have other types. So I'm sorry I didn't cover everyone, but it's good to know that the audience who doing research. So I hope that this talk will help you understand or review what PROs are and the importance of it. And seems like the topic is somewhat familiar or slightly familiar to a lot of you, so very good. And we have some group that are very familiar with the topic, so please bear with me if I tell you what you already know. So hopefully this session will be a good review session for everyone about patient-reported outcomes. So today I will cover the definition of patient-reported outcomes, or PROs, and understand the importance of PRO, and we will discuss how to measure them, and hopefully that we will be able to select appropriate PRO measures, or we call PROMs, in research and clinical practice. So what is patient-reported outcomes? So the definition from FDA guidance for measuring patient-reported outcomes, PROs are any reports coming directly from patients about their health condition and treatment. PROs cover a variety of clinical and humanistic domains, such as physical function, emotional health, social functioning, and health-related quality of life. So the information provides critical insight to the overall well-being of individuals and their responses to treatment. And also to note that PROs are different from other types of patient-reported health data, such as medical history, family health history, or patient-generated health data, such as we track number of steps per day to track physical activity, or number of hours slept per day. So patient-reported outcomes are different than those patient-reported health data. Mostly patient-reported outcomes are more conceptual or abstract, that we need to find a good measure to capture that concept. And also I want to highlight the difference between quality of life and health-related quality of life. We use these two terms interchangeably, but actually they have some distinct difference. So quality of life is everything surrounding us that impact our life in the context of culture where we live and in relation to goals, expectation, and our standards. So quality of life, this is a definition from the WHO. Why health-related quality of life? From the term, you can see that this is a health-related. So generally consider all the quality of life that get impacted by disease or condition that impact our daily functioning and perceived health. So quality of life and health-related quality of life are different and should be used correctly. In general, what we use in research, in clinical practice, we talk about health-related quality of life. So when do PROs become essential? Patient-reported outcomes become very important when the health issue that only patient is the best source of information, and that disease or condition has no physical or physiological markers of disease activity. For example, we are familiar with collecting temperature, right? We do screening every day. That is like physiological marker of fever or, condition, or blood glucose, or forced air volume to determine the diagnosis of lung condition. However, the important thing is that physiologic measures are not necessarily correlate with the functioning of physical activities of patient. For example, this gentleman was doing very well in the exercise test in the hospital. However, he had difficult time doing daily activity at home, such as mowing. So physiological marker is not necessarily correlate or reflect how patient is doing in daily living. So I would like to highlight the value of patient-reported outcomes. The first target group, direct to patients and clinicians. So patient-reported outcomes can be used for individualized patient care decision to help prioritize, treat, monitor disease symptoms and health status. Next, hospital leaders and clinicians. Patient-reported outcomes data can be used for quality improvement to help monitor and improve aggregated patient outcomes as compared to national best practice and benchmark. Patient-reported outcomes also help insurers and hospital leaders to create the value-based payment for the care that we provide, to measure outcomes as compared to cost and utilization to optimize healthcare value. Lastly, and importantly, patient-reported outcomes data can be used among researchers, policymakers, and funders to determine population health and research, to generate new evidence for best clinical practice across patients to achieve optimal health status over time. Next, we're gonna talk about how to measure patient-reported outcomes. Everyone familiar that, when we go to see physician, clinician will ask how we doing. So patient-reported outcomes have been included in practice long before we actually have an instrument to measure them by just asking patient. However, the important question is that if patient-reported outcome instrument really better than just asking a question, how is your pain? Or how are you doing since I last saw you? Patient-reported outcome measures or PROMs. The important that different than polls or just a survey or a question is that PROMs are a standardized, valid set of questions for collecting health status to capture something that abstract cannot be captured directly. And these set of questions can obtain the outcomes that we want to measure directly from patients. To summarize, that PROMs are standardized assessment and often used to measure repeatedly to collect outcomes to evaluate the impact of treatments or progression of disease. The important is that PROMs are developed to iterative psychometric and clinical content review, and then are validated among target patient population to evaluate the psychometric property before use. So you can see a lot of term here that the PROMs is an instrument, it's a standardized assessment that need to have a good psychometric properties. So the question to the audience is that, what are important psychometric properties of the measures? You can see the question pop up here. The first is validity, next reliability, responsiveness, or all of above. Just to see if you know about psychometric properties. Do we have the results? Okay. This is not a trick question. And I just want to see, okay, oh my goodness, 100%. So you all know the topic. Now it's get a little bit intimidated to talk about psychometric properties. So I'm just gonna review what they are. So first, you all correct that those three are important psychometric property, but I would like to highlight that validity is the most important psychometric property of PROM, because validity shows the soundness and accuracy of the instrument to get the result that satisfy objectives. So the instrument is supposed to measure or designed to measure what we intend to get. So we look at the content validity, the content of the set of questionnaire or prompts, and how it construct. Look at content and construct validity. Reliability also important because it's show the reproducibility or consistency of the result. If the health condition doesn't change, we should get the result the same every time we measure when using standardized or valid PROMs. Reliability is necessary, but not sufficient to determine validity. I will show you a little bit more why the difference between validity and reliability. We need both. So think about, this is just example to show validity versus reliability. Think about when we go to target practice. This is the target that we normally see. So the goal is to hit bullseye, to get 10 here. Think about the measures that we want to capture here, 10, the bullseye. So we want to, every time we want to measure things, we should be able to capture the construct or concept that we want to measure here. So look at the set of practice. So from using the instrument, you can see that, let's say 10 times, that you practice or use the instrument, it goes surrounding here, not here. We want it to be here. So you can see that the instrument provides a reliable result, meaning that it's reproducible, going to close to the same spot. But it's not valid because it doesn't touch the concept we want to measure. So precise, not accurate. Next, we look at this set of practice. So you can see that it's getting surrounding to the concept that we want to measure, be able to hit only one. So it's getting close to the instrument that we need, but the validity we can say that it's valid. It's close to the concept that we want to measure, but it's not reliable because it's go all over the place. So not precise, but more accurate. Next, we see the set of practice here that all over the place. This is the worst instrument, not reliable and not valid. So we want the instrument, patient-reported outcome measure, that reliable and valid. Every time we measure, we get the result that meet our objective of measures. So that is the validity and reliability concept of psychometric properties. The last property that's important for the measure is responsiveness. Responsiveness is the ability of the instrument to detect changes in health status when health status change, right? So when you provide treatment or intervention to patients, so when the condition improves, the instrument should be able to capture the change. So the change in score that provide a clinical difference or patient feel the change. So that is called minimally clinical important difference or MCID. So I have a next question for you. So I think a lot of you are familiar with numeric pain rating scale, 0 to 10. So the question is that how much change on this 10 scale for pain that is read to the clinical important difference? 1 point change, 2, 3, 4, or you do not know. So this is example of a pain scale that I think a lot of clinics use in practice. So the important is that how much change that actually significant clinical important difference. So this is true, the question, this is true for both acute and chronic pain. So we'll see if you know this. And we have 20% of audience know that we need at least 2 point change to, that is the minimal clinical important difference of this scale. And the research show that both acute and chronic pain, the average of the MCID is about 2 points. So if patient has changed only 1 point, that it means that the intervention does not work. So the pain should reduce by 2 points to have clinical significant importance for patient, and it can interpret that the treatment reach the benefit to patient. So now we can move to the next set of PROMs. I would like to highlight that there are 2 different types of PROMs. First, generic measures. Second, disease-specific measure. From the name of the measure, you get the idea, right? That the first set is generic. That can be applied to any health problems or condition, and can provide comprehensive information because it captures overall health-related concept or health, perceived health of patient. Therefore, the result from generic measures can be compared across study and population. However, because the question, the items in the instrument is so generic, so it's have limited responsiveness to change, because the question is not specific to any disease condition, so it has less responsiveness when compared to disease-specific measures. So disease-specific measure have more questions that tailor to the problem or condition specific that impact patient's life. So have better responsiveness to change. So I believe that you're familiar with SF36. So you're probably thinking about, the acronym called PCS, MCS, Physical and Mental Component Score. So I just want to see if you know whether SF-36 is generic or disease-specific PROM. SF-36 has been used in clinical practice and research over 20 years. It's been it's developed, I think, in 90s. So it's been used in thousands of research. So almost everybody knows that SF-36 is generic one. So you can use SF-36 to any disease condition. And also you can compare across disease condition and even population to see, how the impact of different disease condition to health-related quality of life. So traditionally, we are familiar with, collecting patient-reported outcomes to paper and pencil. So when we look at clinical practice, when you go to a clinic, traditional way that we collect patient-reported outcomes, a lot of places still collecting in this way, is actually put paper instrument, print it out and put on the clipboard at the check-in. Somebody at the front desk give you the clipboard and then you fill it out prior to see your doctor. So as the way that we collect paper and pencil outcomes from those data collection, it has several advantages and also mostly easy to integrate into the workflow in the clinic. However, the issue is that the traditional way have a limit in terms of scalability and sustainability. So you have to think about the paper and pencil. So in the clinic, you have a collection box, right? All the paper that patient completed go to the box and need somebody to score them and put them into the system or record them into a chart. So it needs manpower to do so over time. And also it's limit the ability to visualize the patient-reported outcomes data and capacity to engage patients outside the healthcare setting. So this has many advantages and also disadvantages, especially in this now, technology has progressed vastly. So there's a better way to collect patient-reported outcomes. So we are talking about how patient-reported outcome has been used in clinical care. So we're familiar with, different clinical care setting. For example, this is just example of how we use patient-reported outcomes or collecting patient-reported outcomes in clinical care as a preventive care to monitor depression or distress in a patient. So we just administer PHQ once a year or annually at wellness visit. Or you can incorporate patient-reported outcomes measures in chronic or specialty care and design, how often you want to monitor like this is still PHQ collecting depression and distress over time, or in surgical care, decide when you expect that patient will improve or patient would, have worry about their condition. So this is how we decide depending on the objective of each clinics. So now we go through how to measure or collecting patient-reported outcomes in research and clinical practice. So we have to think about the measurement strategy. So we have to have a clear rationale for measuring PROs and also have a good reason for selecting particular measures, because now we have hundreds, not thousand, if it's not thousand PROMs to select from. So we have to look at measures that have established psychometric evidence because we want the result to be valid and reliable. And also need to have evidence that those outcomes, patient-reported outcomes, are important to patients and have a clear research goal or question for doing so in measurement. Then we need to think about resources. The important to actually incorporate patient-reported outcomes into clinical care is to have governance support, because we actually need a village to make it work and make it sustainable for future and continuum of care. And the most important that we have to consider is administrative burden. We need to avoid or minimize unnecessary burden for patient and care team. We can't collect everything. I know that we always think about, oh, it's good to know, always need to, we should look at this or that. But important is that we need to prioritize what is the most important outcomes that serve or meet the goal of the care or research, and then select the minimum set of the measures to achieve the goal. When we incorporate the patient-reported outcomes collection in the health system, we need to think about how to standardize the PRO collection across the health system so we can avoid the duplication. We need to work together horizontally, not silo clinics by clinic. So it needs an effort to learn and try to start thinking about having the governance to create and integrate patient-reported outcome data collection in the healthcare system, and decide the timing when to measure and how often to collect those data. The important is we are at the point that we should thinking about incorporating patient-reported outcomes into electronic health records, because now we enable ourselves to monitor patients systematically over time that can produce the aggregated data to improve, to provide value-based care to patients, and also can help to monitor the quality of care in our system. So we need to think about whether we need multiple mode of administration to collecting patient-reported outcomes. Are we going to use the combination of paper-based, paper and pencil administration, or we can integrate electronic patient-reported outcomes data collection? If we want to use electronic patient-reported outcomes measurement, we have to think about how to customize the content and functionality for reporting, because we need the data to be usable and have a usability to clinicians and hopefully patients as well, and how to align it with the clinical workflow in the health system in the clinic. And also we need to think about where we're going to store these data and how we can enable the reporting tools. It's going to be in the same electronic health records or in the cloud somewhere. And also need to consider IT infrastructure in the organization. I work with clinical informatics in UMS. They are excellent. They are very, very helpful and knowledgeable. So I think we have very good IT infrastructure to integrate patient-reported outcomes into Epic. So there's no one-size-fits-all in a solution. So it depends on the health system to have more integrated or less integrated. The most integrated system will be everything is in EHR. So we integrate the PRO data collected and stored in our native system. Or we can have a hybrid system. We have the data collection through, for example, we use a lot of REDCap delivery. So we collect peer data in REDCap and then incorporate or partially integrate it into EPIC. Lastly, the least integrated is to keep it totally separate, never integrated into the third party only, store in REDCap or Qualtrics or SurveyMonkey that never integrate into health system. I believe that is the least usable because it's hard to report or use in clinic outside the research arena. So I would like to introduce the PROMIS. The PROMIS is a patient-reported outcomes measurement information system, which has many measures that are already validated and developed from NIH. So NIH has a big toolbox of these PROMs that can be used in research and also for clinical practice. And the exciting part is these measures, a lot of them are available in computer adapted test or CATS format that can be quickly and efficiently administered to patient. It's reduced the number of questions the patient need to complete. So it's very useful and minimize the administrative burden for patient and save time. And PROMIS CAT can be administered and recorded in the integrated manner, such as in EPIC. So I'm very excited when I figured it out and I found that PROMIS CAT is available in EPIC. And there are many institutions in the United States and Europe that use PROMIS that integrated into the health system. So we think about the opportunity to have aggregated patient-reported outcomes from across the country, even across continent, for different conditions. So it's a very, very good tools, PROMs to use. And in EPIC, we can see the patient-reported outcomes data in the point of time and also the longitudinal integration when we monitor patient over time. And physician can enable the reporting tool so they can have the patient-reported outcomes in the dashboard. How excited is that? How exciting is that? So we can see how patient is doing and can use that information to communicate and tailor the treatment that provided to patients. So this is very exciting. So right now we have two ongoing patient-reported outcomes project at UMS that's supported by PRI Team Science. The first one is iPro Pain Initiative. I work with Dr. Gori in his pain clinics and try to incorporate PROMIS CATs in pain clinic workflow. So we would like to assess patients and clinician acceptability and usability of the PROMIS. We use all PROMIS CAT and identify preferred data reporting for clinician and patients, not only clinicians. This is a mistype for me. And also the second project led by Dr. Bumpas. So he and his team, including myself, are working on the Center for Musculoskeletal Value and Outcomes Research to integrate the patient-reported outcomes, healthcare informatics, healthcare management, and also the cost to improve the musculoskeletal care value in Arkansas. So these are two ongoing projects that started this year at UMS. So we're very excited and very fortunate to get support from the TRI Team Science. So I would like to summarize the talk today by introducing you another tool that you can refer to later on. It's a user guide for implementing patient-reported outcomes measure in clinical practice that provided from International Society for Quality of Life Research. So these are 8 steps to implementing PROMs. First, we identify the goals for collecting patient-reported outcomes. Then we select the PROMs, selecting the patient, setting, and timing as well, and determine which ones or how many of them we're going to use, and selecting whether going to be paper and pencil or electronic, and decide the process to report results. Next, we identify aids to facilitate score interpretation, because we have to think about how we communicate with the team, with clinicians, with patients, and then develop strategy to, when we have issue, identify by PROMs, how we can address that. And then lastly, the most important, to look at evaluating the impact of the measures, the patient-reported outcomes on the practice, how it changed, whether it improved the value of the care, whether it make it better in helping patient-clinician communication, and also to look at the efficacy of the treatment or intervention that we're providing to patients. So in summary, patient-reported outcomes are important to patients because we are promoting patient-centered care. And also PROs are important for provider and care team because we use the data to help in this making a good decision. And also we help the health system to improve care quality and care delivery. And lastly, patient-reported outcomes can be used for payer and policy to look at population health and outcomes. So there are a few points to remember that we talk about patient-reported outcome measures that are not polls, that are not just a survey. It's a validated assessment that we capture the outcomes that come directly from patient. So I hope that this session will help review about patient-reported outcomes and also the measures that can be used to collect them, and also the guideline how to selecting appropriate measures in research and clinical care. So if you have any question, this is my email address, and I'm happy to answer any question from the audience. And also thank you again for TRI Research Fundamental series for the invitation to talk today. And thank you everyone to attend the session.
Suppose a potential PROM is reliable, but its validity is in question. If the potential PROM is repeatedly measured, might it still be useful when looking for changes in health status?
So the question is about reliability of the measure.
No, I'm more about the validity of a potential PROM. If we want to, I mean, so you have a investigator developed instrument, and you're trying to get at to find out if it's valid, but you have a pretty good idea that its reliability is good, but you want to use it to see if it finds changes in healthcare. You know its reliability is okay. You're going to repeatedly measure a patient. If it's reliable, but you're not sure if it's valid, can that help establish the validity?
For as working in this field for many years, that is every time you use any instrument to measure PROs, I would suggest that you need to test the validity. So psychometric properties of psychometric testing is important to be done in the target population and also the condition that you use, even though that they are valid in different population or condition, doesn't mean that it will work or it's valid in the target population that you use. So the important thing is to establish validity of the instrument in the target population before you actually comfortably report the result. So it's important to establish the validity. So I would suggest that you do the validity testing. Not only, we are familiar with Conrad alpha, right? A lot of people think, oh, you look at it's reliable, it has to be valid, but it's not true. So you have to look at, it has to have established content validity first, and then you can test the construct validity. So I would suggest that you run psychometric testing so you feel comfortable to use it.
A group and I are looking at using this measure, some of these measures on older adults to see change in reported in their subjective health from an intervention. But it seems, for example, we see a lot of information on the SF36 or the LLFDI for older adults, but we can't find a lot of studies with PROMIS tools and responsiveness of interventions among older adults. Am I missing something? Are you aware if there's data out there?
I think that's specific to PROM that you select, but in special population like young children, adolescent, and also elderly, there are limited data on that. So I would suggest that if you would like to also make sure that the instrument that you pick is responsive to the population. In general, we can mostly what I do is to at least use 2 instruments to hopefully that one will work, one may be more sensitive than another, and also have other clinical measure as well to see how it related or correlated with the, if we have a gold standard of measure and we can establish responsiveness. So this is the important area that is not well studied to establish like MCID for all the scores. I don't believe that PROMIS has established all the MCID in all different populations. So it's mostly has been tested in general population, in not in elderly population. So I would suggest that maybe you can thinking about that, maybe the exploratory goal for your research, and establish that. So that is something that needs to be done. I hope that you get something takeaway point from this talk, because I know that I present more generic because I want to make sure that everyone will learn from it. But if you have more specific questions, particularly to your research projects or your clinics, feel free to send me an email, and I'm happy to answer in more detail or have a discussion in terms of how to, if you run into some hiccups in the project and are not sure whether which instruments are better, because we always need to test, the sensitivity and also responsiveness of instruments. So I always, that's my first rule. I run psychometric testing on all the instruments that I use in variety of the projects, because those information is a lot of time has been ignored, because people, it's validated, it's already valid in whatever in the literature has been published, but it doesn't mean that it's valid in your population or conditions. So it's always, the psychometric properties is attached to the population that's been tested are using. The properties, the psychometric property doesn't carry across population, age, or condition. So it's always, useful information for you to run the psychometric testing of the instrument that you use. So that is something that I do regularly for any project.
Thank you so much for coming and talking to us today. I really appreciate it. And don't forget, our next Research Fundamentals will feature Dr. Curran, who's going to talk to us about implementation science. So we hope to see you in November.